Radiation treatment can actually be given to all stages of stage 3 disease in general. But of course, stage 3 non-small cell lung cancer is very heterogeneous, not only because the patient can be very heterogeneous, because of the performance status, the age and so on, but also the anatomical location can be very different. And we see some patients with stage 3 disease which have a total volume of the tumor in the lymph nodes of, say, something 50 milliliters, and some patients at diagnosis have between 300 and 400 milliliter, but the average patient has a volume of tumor of about 120 milliliter, and that's quite large. And depending on the location of the lymph node, of the volume of the primary tumor, you can offer them radiation together with chemotherapy most of the time, and sometimes you also add surgery, certainly when the volume of the tumor is 5 centimeters or more, something like that, or has already some excavation, so central necrosis, which lead to abscedation. And when you treat them with radiation, sometimes you don't have an alternative, but when you treat them with radiation, then this may lead to abscedation, to chronic infection, and it's of course even lethal in some cases. So, but most of the time we can treat those patients with radiation. There's no added value for surgery that has been shown in randomized studies, unless in specific cases like I mentioned. And on the other hand, we treat the patient, if possible, also with systemic treatment, because at the time of diagnosis, even though it's not detectable on current PET-CT scans, about 80% have already distant metastasis. And that's the reason why it's so important to integrate systemic treatment with radiation. Patients with poor performance status occur very frequently in lung cancer group, and that is because patients have smoked a lot. Most of the time they smoke between 30 and 60 pack years, so a lot of those patients have lung emphysema, have heart disease, have stroke, so all those things happen before in those patients, and because of that they frequently have a poor performance status. Performance status is defined as a WHO score of 2 or more, and it's very difficult to know exactly what we should do with those patients. The only thing what we do know for sure is that you shouldn't harm them too much, and probably it's best not to treat them with concurrent chemotherapy and radiation. It's probably better to give them chemotherapy followed by radiation, the so-called sequential approach, and in some cases it's probably also better to treat them palliatively, certainly in the case of performance status 3 or 4, because if you treat them aggressively, you will use so much toxicity that not only the quality of life is very bad, but probably you will really kill some patients by treating them too aggressively. So it's much better to give them then sequential chemoradiation or radiation alone.